Hello everyone. Today I am going to tell you the details of cardiovascular system examination in newborn baby. So first is inspection. In inspection, you have to see the baby is having the any sweating over the forehead, central cyanosis is there or not, or having the normal body color, any sign of congestive cardiac failure, shock, any syndromic facial features. Then check the apical impulse is present in normal position or any deviation is there. Any visible precordial pulsation, scar and veins if present, then we have to mention in inspection. Cyanosis is a bluish discoloration of the skin and the mucous membrane. Here in this image you can see nails are cyanosed, and in this image you can see lips and palm are cyanosed. It is appear whenever there is more than 5 gram per dl unoxygenated hemoglobin present in the blood. Cyanosis appear at a higher level of oxygen saturation in polycythemic newborn baby, while in the anemic baby at a very low level of oxygen saturation cyanosis will be visible. So whenever anemic newborn is having the cyanosis, that means having the very low level of oxygen saturation. Type of cyanosis either central or peripheral. Central cyanosis whenever there is uh, cyanosis is at the tip of tongue, lips and oral mucosa, we label as a central cyanosis. While the peripheral cyanosis, when the palm and sole are cyanosed, while the other body part is pink, we label as a peripheral cyanosis. Central cyanosis because of the lung and heart diseases. So whenever there is airway obstruction, lung diseases or congenital cyanotic heart disease or shock, baby will have the central cyanosis. In peripheral cyanosis, it is because of vasoconstriction occur. It is very common in the hypothermia. In type of cyanosis in Viva, it is also asked what is cyclical cyanosis, when it is present, what is a differential cyanosis, what is reverse differential cyanosis. So basically cyclical cyanosis seen in the bilateral choanal atresia. In this, when the baby is crying, baby become the pink normal color because baby can be able to take the breath during crying. Mouth will be open. When baby will stop the crying, baby will again become the cyanosed. In newborn baby, they are the nose breather. They do not know how to take the breath from mouth. So whenever there is a bilateral choanal atresia, they will have the severe respiratory distress and central cyanosis. So as the cyanosis will increase, then baby will cry and it will again disappear because breath baby can be taken by the mouth. When baby is crying, mouth is open. So it is a cyclical cyanosis, while the reversed occur in the congenital heart disease. Intermittent cyanosis seen in the Epstein anomaly. In congenital cyanotic heart disease, baby is having the more cyanosis, exaggerated cyanosis when the baby is crying. While when baby is calm, cyanosis is either mild or less than compared to the crying. So it is reverse of the this situation. Now the differential cyanosis and reverse differential cyanosis. We label the differential cyanosis whenever there is a oxygen saturation is more in the right hand compared to the foot. So in this condition, patient is having the pink right upper extremities, preductal, while the cyanosed lower extremities. This situation seen in the patent ductus arteriosus with pulmonary artery hypertension, or we can say with reversal of shunt, and also in the coarctation of aorta. While the reverse differential cyanosis when right hand is cyanosed and foot are normal color. So oxygen saturation is more in the foot compared to the right hand. It is seen in the transposition of great artery with PDA and elevated pulmonary vascular assistance, or in the TGA with PDA and preductal aortic interruption or coarctation. So we have to remember the what is the meaning of differential and reverse differential cyanosis, and also the example. Now check the clinical features of the congestive cardiac failure is there or not. So baby is having the poor feeding. Whenever you will ask the history of the feeding, mother will say baby is not continuously taking the breastfeed for 20 minutes. There is a suck rest cycle present. So baby will suck for few seconds, then baby will stop feeding, then again suck, then again stop. So this is characteristically seen in the congestive cardiac failure. Poor weight gain will be there. Tachypnea increase during the feeding time. So during the feeding, especially baby is having the more difficulty in taking the breath. Cold sweat over the forehead, sweating over the forehead, especially during the feeding time. Again, you have to think about the congenital heart disease in the newborn baby. And edema can be present because of congestive cardiac failure. Now, according to the time of onset of congestive cardiac failure, we can make the differential diagnosis. So, in the first 72 hours of life, valvular stenosis or atresia can present as a CCF. So, pulmonary aortic mitral valve atresia or critical stenosis will lead to the congestive cardiac failure in first 72 hours of life. Between 4 to 7 days of life, if newborn baby is presented with the CCF, then you have to think about hypoplastic left-right heart syndrome or TGA with poor mixing. If after 1 week of life, between 1 to 4 weeks, then think about TGA, endocardial fibroelastosis or coarctation of aorta. Then check for the any sign of shock is present or not. Prolonged capillary refill time, mottled skin color, tachypnea, tachycardia all suggest that patient is having the shock. Then check for the syndromic facial features. So if the baby is having down faces, then endocardial cushion defect VSD can be there. If having the congenital rubella syndrome, then patent ductus arteriosus can be there. Turner syndrome, coarctation of aorta. In trisomy 13, VSD, ASD, PDA, dextrocardia is associated. In trisomy 18, VSD can be there. Then apical impulse. It is the lowermost outermost point of cardiac pulsation. In newborn baby, it is almost half to 1 centimeter lateral to the left mid-clavicular line in the fourth intercostal space. It can be shifted to the same or opposite side if the patient is having the pathology. So lateral and inferior shift of apical impulse seen with the left ventricular hypertrophy and left ventricular enlargement. Only lateral shift of the apical impulse seen with the right ventricular hypertrophy. On right side seen whenever there is dextrocardia or left-sided pneumothorax. Then check for any visible precordial pulsations are present over the chest. In aortic area, if pulsations are visible, then AR aortic aneurysm can be there. If in pulmonary area, then pulmonary hypertension can be there. In carotid, in neck area, it can be seen whenever there is hyperdynamic state. Example, in patient is having the severe anemia. In coarctation of aorta and AR, pulsation can be visible in the neck. In supraclavicular area, seen in the AR. Inter and infrascapular area, seen in the coarctation of aorta, Sujman sign. In epigastric area, seen in the AR and RVH. In hepatic area, seen in the TR and TS. After inspection, we should confirm all the findings of inspection by palpation. So in this, we should palpate for the apex beat, point of maximum impulse, thrill, any palpable precordial pulsation or palpable heart sound. Peripheral pulses should also be palpated and mentioned over here. Capillary refill time and signs of congestive cardiac failure. So apex beat should be localized by the fingertips and localization should be done also with the single digit. Normally located half to 1 centimeter lateral to the mid-clavicular line in fourth intercostal space. It can be shifted whenever there is a pathology. Now we have to check the character of apex beat when we are palpating. Normal character means it is localized to the one intercostal space, not forceful and present in less than one-third systole. While the heaving apex beat is forceful and it is well sustained. Well sustained means it is present almost more than two-thirds of the systole. It is seen in the pressure overload condition AS or coarctation of aorta. Hyperdynamic apex beat we mentioned whenever there is apex beat is forceful but it is ill sustained, means it is present in one-third to half of the systole. But hyperdynamic apex beat almost present in the more than one intercostal space, while the heaving present in the one intercostal space. Hyperdynamic seen in the volume overload condition whenever there is a regurgitant lesion or shunt lesions. After apex beat, we should palpate for the point of maximum impulse, PMI. It is the area where the maximum impulse we can palpate. So if patient is having the right ventricle dominant, then it is feel at the lower left sternal border. If left ventricle is dominant, then it apex. And we should use the fingertip to palpate the PMI. Then we should palpate the thrill by using the palm of our hand. It is a vibration which we are feeling. It is corresponding to the sound of murmur. So it is always pathological whenever thrill is there. We can use the fingertip whenever it is in supraesternal notch or over the carotid area. Over the precordium, we should use our palm of hand. Then according to the location of the thrill, we can make the differential diagnosis. Example in carotid and aortic area. In aortic stenosis, in pulmonary area, maybe because of PS or ASD, continuous palpable thrill in the pulmonary area can be because of patent ductus arteriosus. In lower left parasternal area, because of ventricular septal defect. Palpable heart sound, if it is present, then we have to mention palpable P2 in pulmonary hypertension, palpable A2 in systemic hypertension and aortic stenosis. Palpable precordial pulsation can be seen in various conditions. In aortic area, palpable precordial pulsations can be because of AR or aneurysm or dilatation of ascending aorta. In pulmonary area, because of pulmonary hypertension, carotid, because of hyperdynamic state or coarctation or AR. In supraclavicular, because of AR. In inter-infrascapular area, in coarctation of aorta, known as Sujman sign. In epigastric area, because of AR and right ventricular hypertrophy. So we have to check the either it is palpable at the pulp of the finger or at the tip of the finger. So if it is at the pulp of finger, then possibility of AR, and if it is tip of the finger, then RVH. In hepatic area, TR and TS. Then all peripheral pulses should also be checked whenever we are mentioning the palpation in the cardiovascular system. Brachial pulse for the rate, rhythm and volume. Femoral pulse always we should check because diminished femoral pulse and brachial femoral delay seen in the coarctation of aorta. Whenever we are suspecting cardiovascular disease in newborn baby, all four limbs BP should also be mentioned and pre and post ductal saturation should also be mentioned in the palpation. Now the capillary refill time. Here in this video you can see we have to apply the moderate pressure for 5 seconds over the chest to blanch the skin, and then we have to release the pressure and we have to observe the time which is elapsed before skin regain the normal color. Normal CRT is less than 2 seconds. Between 2 to 3, borderline abnormal, and more than 3 considered as abnormal, seen example in shock or hypothermia. Then we should mention all the signs of congestive cardiac failure in palpation. So we should mention the size of the lever which is palpable, then also the tachypnea, tachycardia, edema as we had mentioned in the inspection. JVP not reliable in the newborn baby. There is no role of percussion in CVS examination in the newborn baby. Now in auscultation, we should auscultate for the heart sounds, and if murmur is present, then detail of it we should mention. So normal heart sound S1, S2. S1 is because of closure of atrioventricular valve. It is lump sound, low pitch sound, prolonged sound. While the S2 because of closure of semilunar valve. It is dub sound, high pitch, short. Two components are there. Physiological splitting occur between A2 and P2 component and also varies with the inspiration and expiration. Abnormal S1 heart sound according to intensity, loud S1 because of sinus tachycardia or if the newborn is having high output state. Muffled S1 can be because of pericardial effusion. Abnormal S2 sound accentuated in aortic regurgitation, loud A2 will be there, and in pulmonary artery hypertension, loud P2 will be there. Diminished sound, diminished A2 sound in aortic atresia and diminished P2 sound in pulmonary stenosis and pulmonary atresia. Delayed A2 can be there in AS, PDA, AR, left ventricular failure and left bundle branch block. Delayed P2 can be in pulmonary stenosis, atrial septal defect, TAPVC, total anomalous pulmonary venous return and RBBP, right bundle branch block. Early A2 can be seen in the ventricular septal defect. Now splitting of the second heart sound. There is normal splitting occur during the inspiration. So this red block is suggesting A2 and this green block P2. So during expiration, no splitting occur, while in the inspiration, there is a splitting between A2 and P2 occur. Normally A2 sound before the P2. Wide and variable splitting during both inspiration and expiration occur whenever there is a ventricular septal defect, pulmonary stenosis or mitral regurgitation. Wide and fixed splitting occur in atrial septal defect, TAPVC and right bundle branch block. Paradoxical splitting means P2 before A2 occur in aortic stenosis, patent ductus arteriosus, aortic regurgitation. Single second heart sound audible in tetralogy of Fallot's. In abnormal heart sound, S3 and S4 sound always abnormal. S3 sound, third heart sound S3 gallop, it is due to the rapid ventricular filling seen audible in myocarditis, congestive cardiac failure. Audible fourth heart sound S4 due to rapid emptying of atrium in constrictive pericarditis or in hypertrophic cardiomyopathy. After the heart sound, we should also auscultate for the any murmur is audible or not. So murmur is caused by the normal flow through the abnormal valve or abnormal flow through a normal valve. Murmur can be organic or it can be flow murmur or it can be innocent or functional murmur. So we have to describe the murmur by intensity, pitch, timing, variation with the respiration or posture. Area of maximum intensity of the murmur is very important because we can make the differential diagnosis. Then conduction of the murmur to the other area. Then we should grade the intensity of the systolic murmur. 1 when it is barely audible. Medium intensity 2 grade. Loud but there is no palpable thrill. Then 3 grade. 4 when loud with thrill means during palpation you also feel the vibration of the murmur. 5 very loud, still need the stethoscope on the chest. 6 audible even with the stethoscope off the chest. According to the timing, type of systolic murmur, either ejection systolic murmur or pan-systolic murmur or late systolic murmur. Ejection systolic murmur seen in the aortic stenosis, pulmonary stenosis and atrial septal defect. Here in this image also you can see this diamond shape of the murmur in aortic stenosis. While in the uh, here you can see this is pan-systolic murmur in tricuspid regurgitation and in the mitral regurgitation. Late systolic murmur seen in the mitral valve prolapse. So here in the image you can see this is late systolic. Now we have to grade the diastolic murmur according to the intensity. So very soft murmur grade 1, soft 2, loud 3, loud with thrill grade 4. Now according to timing, type of diastolic murmur, early diastolic murmur in aortic regurgitation and pulmonary regurgitation. Here in this image you can see this is early diastolic murmur of AR. Mid diastolic murmur seen in the mitral stenosis and tricuspid stenosis. Here you can see this is mid diastolic murmur of MS. Functional murmur, Graham scale, Kericombe murmur, Austin Flint murmur as seen in the aortic, so can be there. Now the murmur according to the area of maximum intensity. If maximum intensity of the murmur is present in the apex and mitral area, then you should think about either having the aortic stenosis, mitral stenosis or regurgitation, or it can be functional. If it is present in the tricuspid area, then ventricular septal defect, TR, TOF or endocardial cushion defect. If it is present in the pulmonary area, then think about the ASD, PDA, PS, AS and TAPVC. If present in A1 aortic area, maximum intensity, then AS and AR. Along the left sternal border, early diastolic murmur of ARPR can be present. So according to the maximum intensity, we can make the differential diagnosis. And about the all areas, I have already explained in the one of my video on cardiovascular system examination, where the tricuspid area, pulmonary area present. We should also keep in mind that in newborn baby, most of the murmur are transient and benign murmur, which is very common in the newborn period. It is usually caused by PDA, patent ductus arteriosus. PDA murmur is continuous machinery murmur. It is harsh quality and best heard under the left clavicle and also radiate along the left sternal border. So we should also keep in mind in newborn baby, especially functional transient benign murmur can be present in first 72 hours of life because of PDA. Now what are the characteristics of functional murmur? It is short and soft murmur, systolic murmur and grade 1 and 2. There will be normal S1, S2, murmur is not radiating to other area, normal cardiac impulse, no evidence for any hemodynamic abnormality, then we will label as a functional murmur. Pathological murmur, here you can listen pathological murmur. Pathological murmur, either pansystolic murmur or all diastolic murmurs are pathological. Murmur associated with the pill always pathological. It is harsh quality. You can listen to this sound also, the abrupt third sounds, and it can also read. So thank you so much. This is all about the cardiovascular system examination in the newborn baby.